Okay, guys, this is the second half of Module 2, which is Intrapartum. This is going to cover electronic fetal monitoring and delivery. All right, so when we talk about electronic fetal monitoring, this is what I'm talking about. The monitor here is on the left. You can see the paper rolls out of it, just like, say, an EKG machine, except these strips just continue on and on and on the entire time mom is on the monitor. Of course, you can switch them now with computerized fetal monitoring to the computer is storing it. But if you need a quick version that you can, walk into another room and show the physician, you still have that paper ability is basically where I'm going with that. So the picture on the left with the fetal monitor, when you're looking at it, the left-hand side of the paper is baby, and the right-hand side of the paper is mom's contractions. Looking at the monitors here on mom's belly, the blue one on the top, well, the blue band, the white, is actually the transducer that does contractions. It's called the TOCO. The one on the bottom with the pink band that is blue is the ultrasound transducer, and that is listening to baby's heart rate. This is the fetal monitoring strip, so that's the paper that's coming out. This just shows where those monitors are placed on mom's belly, what it is looking for, what's it listening to. So if you look on the right at the fetal monitor paper, the top of that paper is all baby's heart rate. The numbers correspond to the beats per minute. So if I say the baby's heart rate is at 120, that's 120 beats per minute. On the bottom is your uterine contractions. There are numbers that correspond to that too. Those numbers we only read if patient has internal monitoring in. Most of the time this is done externally. So basically the uterine contraction part of the monitor, if it's external, is just showing us that there is abdominal tightening, not how hard those contractions are. Between the dark red lines is 1 minute. Between each little box is 10 seconds. So there are 6 little boxes that equal to 1 minute between the two dark red lines. That's how we read those. All right, electronic fetal monitoring. So when we were talking about how do we read the contractions, so remember we start at the beginning of one contraction, it goes to the beginning of the next contraction. So looking at this fetal monitor strip, we look at the beginning of the first contraction, and that is about a minute long. You could count the little boxes from the time that starts going up to the time it starts coming back down. That's going to be very close to about 60 seconds. And then you'll see where the first one starts. Again, that's about another minute. So you're going to say these are 1 to 2 minutes apart. Okay. That's basically what we're doing with these contractions. We're looking for how far apart are they, when do they start, and then intensity. So intensity is not measurable with external monitoring, intensity being how strong the contractions are. You actually have to have intrauterine monitoring in order to be able to tell how strong contractions are. But remember, that's much more invasive because now I'm putting a monitor inside of mom. So that's not something that we do a lot. Looking at the top, which is the baby, you read them, it's the same scale. You see in this picture how baby's heart rate goes up and down. That's variability is what that means, and we like that. That's good. Baby's heart rate should not stay the exact same rate. It should change back and forth. And when we're looking at baseline, we're going to look at a 10-minute stretch. So we'll talk about that a little bit more as we go through. When we are assessing our babies, remember that the only way for us to really know what's going on, how life is, what's the environment the baby is in, is by looking at their heart rate monitor. So one of those things that we look at is variability, okay? So that's the changes in the heart rate. The heart rate should go up and down. Our normal is 110 to 160 beats per minute, which is very fast, right? And as the baby grows, once baby's outside of mom, as baby gets older, that heart rate will slowly come down and be in a normal range that we see for adults. So looking at the variability over here on this strip, the first one is absent. We see that this line is basically almost flat. That means there's not really any changes in that heart rate. We can tell that it has a decent heart rate. It's at 140, so it's in that normal range. It's just very flat. Okay. The next one is minimal variability. You can see that that line wavers a little bit up and down in there, and that tells us that things are okay. We don't like it, but it's better than no variability. All right, moderate variability is what we like. That means that there's a change within 6 to 25 beats per minute in there. That will give you that very up and down looking strip. So that's normal for us. That one that we looked at earlier, the slide before, that one was the same. That's considered moderate variability. The last one is called marked variability. With that one, we get concerned as well. So because the baby's not having any kind of a consistent baseline. So I should have these nice accelerations, but I should have a stretch of the strip where my heart rate comes back down into a normal range. So those are things that we will be looking at when we're assessing the stuff for baby. So things that can cause changes in variability is hypoxia. So I'm not getting oxygen, right? I'm starting to asphyxiate. I'm getting acidotic. Maybe mom was put on some medications. So maybe I was put on a, mom was putting on a pain medication, or we started some sort of magnesium sulfate, or baby can be asleep. So babies do have about 20-minute sleep cycles where they will go to sleep, and you will see minimal to absent variability while they're sleeping. But once they wake up, then we should be able to see some good, good variability there. So looking at this fetal monitor strip, I know the top is my fetal heart rate, the bottom is my uterine contractions. If I try to count my contractions, starting at the beginning of this first one here on the bottom left, I would count that as being 1 minute, 2 minutes, 3 minutes before the next one starts. So, but the following one starts very quickly. So I would, if I was giving a report to my physician, I would say that this patient is having contractions that are 1 to 3 minutes apart. And that lets him know that they're still on a very irregular pattern. The next thing I'm going to look at is my baby. So first I'm going to look for a baseline. So to get a baseline, I need for baby's heart rate to come down to an area for, you know, a couple of minutes. So in this, we can see we have a lot of variability, right? It's a moderate variability, which is good. We have acceleration. So you have big increases of the heart rate where it comes back down, and then you do have stretches of what we would call baseline. So what you're going to do with that is come up with what is your average of that heart rate because it's moving back and forth so much. You can't say that it's definitively 130, okay? What you're going to do is look at that and say it's an average. So the baseline for this baby could be 130 to 140 with moderate variability and accelerations. So those are the things that I would say to my physician about this strip. So when I'm monitoring for using external fetal monitoring or EFM to monitor a baby, I'm looking for what does the baby look like? If mom's having contractions, how does baby respond to those? What is the normal heart rate and what does the variability look like? So things that can be different things that can cause accelerations. So accelerations are those nice increases in the heart rate. Remember I said that means that things are good, right? Those are caused by a sympathetic response. It usually, accelerations go along with fetal movement, and it tells us that baby is happy and healthy in its environment. Things are going well. Early decelerations are decreased heart rate. Usually an early deceleration is a response to the head getting squeezed. So if my head is starting to be squeezed, that's a good thing. That means that it's the head is descending. It's doing the things that it's supposed to do. So an early deceleration we are happy with. That means that we're reaching the end of this process. As babies have these early decelerations, there's nothing really that we do for that. We're actually very happy about that. So we're just going to say, great, that's a good sign. That means our baby is moving down. This is a fetal monitor strip that is showing us good acceleration. So we see on the bottom, this mom is having beautiful contractions. They're nicely spaced out. I would say those are every 2 to almost 3 minutes there on that last one. Looking at this baby next, I'm going to look at baseline first. So I'm looking at baby being at about 120 to 130 as a baseline. We're having beautiful accelerations. That heart rate increases as I'm having a contraction and then returns back to baseline. So this is a classic, perfect, baby's healthy, mom is healthy, things are good strip. So to continue speaking about early decelerations and head compression, these are what we call earlies in this strip here that we're looking at. This strip, you can see that the baby has a nice baseline heart rate of 140 to 150, I would say. But you see that as the baby has, or mom has a contraction, baby's heart rate comes down. So that means as that uterus is contracting, that head is getting squished, and now I have, because I'm coming down into the pelvis, okay? Early decelerations are a good thing. They usually are more of a mirror to the contraction. So usually as a contraction starts, baby's heart rate starts to come down. As the contraction goes away, baby's heart rate starts to come back up. So these are good things. We like these. Okay, the next deceleration we're going to talk about are variables. So typically variables is a response to cord compression. Usually you will see these in a U or a W or a V shape, okay? They're usually very deep and come right back up with the contractions, and basically what's happening is either baby has rolled over and is laying on the cord, so every time there's a contraction, that cord is getting squished between the baby and the uterine wall, Sometimes babies like to hold their cords, and as that contraction comes, they'll squeeze it because they're not really in control of those things. But then they'll let them go, and then that's why the abrupt return to baseline. If we stay like this for a while with these deep variables, we can get into trouble with having a baby getting very acidic and having some sort of issues once we're delivered. But most of the time, especially if it's definitely a cord, then we can do some interventions. As a nurse, we can change position, do some oxygenation, and sometimes those things will help take care of this. Okay, so the next kind of deceleration that we're going to talk about are late decelerations. This is telling us that there's something wrong with the placenta. So for some reason, placenta is not working like it once was. So now we have some really deep decelerations of the baby's heart rate. These are something that we definitely have to do some resuscitative matters for the baby. If it just happens every once in a while, then that's something that we're going to keep an eye on. But recurrent, so that means repetitive, deep decelerations like these are quite scary because they're trying to tell us that this placenta things are not going great. Okay, so usually this is also a sign that baby's not going to tolerate labor very well. But most typically that's because of some sort of placenta issue. So it could be mom has hypertension, or I just got a anesthesia. Maybe I just got some an epidural, and that is causing my heart rate to drop. All those things can cause these late decelerations. So the things that we're going to do for these is we're going to turn mom. Usually the left side tends to be the best side. So we'll turn mom on her left side. If she's getting Pitocin, we're going to turn that Pitocin off. We may give some terbutaline to work on that. We're going to do an IV bolus. We're going to put O2 on at 10 liters on a non-rebreather, and we're going to call our doc. Okay, so those measures that I just mentioned are all considered resuscitative measures. So if we talk about resuscitative measures, those are the steps that we're talking about. So oxytocin, we all know, is that hormone that's normally in the female body. It causes us to have these contractions. Typically, though, people are having to receive oxytocin either to get the contractions on a better pattern, or maybe I'm being induced for some reason. Then terbutaline is one of those meds that we would give to try to stop the contractions or slow them down. Typically, turning that Pitocin off works the best, and we'll turn that off right away and let mom and baby have a little bit of a rest. So this is another version of a fetal monitor strip that shows some late decelerations. Like I said, these are a bit more subtle than the ones we looked at earlier, and sometimes those very subtle ones will creep up on you if you're not really paying attention good to your strip. So these are another version of those late decels. Okay, so this takes all three of the different types of decels. It gives you what they look like on the strip and what's happening with the baby. So looking at our earlies, you can see that baby's head's getting squished as they come down, and what they look like on the fetal monitor strip. Same for your variables. So something is happening with that cord, remember? So in this picture, baby's foot is coming down and squishing that cord against the placenta. or the uterine wall, and that's causing those deep variables. And then the last one is telling us that there's something going on with that placenta, and that is why we're having those deep decelerations. Okay, so this is the easiest acronym to help you remember these accelerations and decelerations. So it's VEAL CHOP, and you're going to read across. So if it's a variable deceleration, that's related to cord compression. Your early decel is related to head compression. Accelerations are okay, and late decelerations are placenta insufficiency. Easiest way to remember those. So some breathing, labor interventions for nursing. So we want to encourage our patient to void every 2 hours or so. Moms are going to get a ton of fluids while they're in labor, and a full bladder will slow down the labor process. We want to make sure that, especially if mom is not wanting to do any different kind of medications, that we do some breathing exercises. Sometimes abdominal massage helps. Sometimes using a tennis ball and pressing them on some of those painful areas. Maybe mom is having a lot of back pain. That can help sometimes. So you want to think about those kind of things. Moms can have some hyperventilation, which causes us some respiratory alkalosis, right? Because we're blowing off too much CO2. So if they start complaining of dizziness, tingling of the fingers, anything like that, we'll go ahead and put a non-rebreather back on, and maybe not turn the oxygen on, just let her breathe into that a few times to get some of that CO2 back in. That's usually the easiest without having a paper bag available. As mom moves through labor, at some point she will become NPO, and she'll just have some ice chips or hard candy. That's important because anytime mom can turn into an emergency and need a C-section. So we want to try to limit the amount of fluids that she's taking in orally. So ice chips is good. Hard candy, gum sometimes is okay. As mom is moving through labor, and usually I like to discuss this early on, as early on as we can, about anesthesia or analgesia. Are they going to want anything for pain medications? And kind of discuss the different things that they can use. And then we want to make sure that we're notifying our healthcare provider anytime we see that labor is slowing down, our vital signs are abnormal, or our baby is having an abnormal strip. Okay, so epidural. So especially in the United States, we use the heck out of an epidural, right? They're quite wonderful. If you are wanting some sort of pain medication, this gives you the least side effects for both yourself and the baby. So those are important things if you're seeking pain medication. So typically they're going to put this epidural in that second stage of labor, usually in that active stage, that 4 to 7. It does, basically the idea is it should numb you the bottom half of your belly down, so those legs are going to be like dead weight, and give you some good pain relief. Mom is going to get lots of fluid before that. We go ahead and have the epidural placed. Anytime you're talking about anesthesia, you can have someone with their blood pressure will drop and get really, really bad hypotension. So that's why we like to pre-hydrate patients, give them fluids up front before we get ready to put an epidural in. We're going to have to keep that bladder empty since mom cannot feel it. We'll be putting a Foley catheter in. When they anesthesia gets that epidural in, they'll give a test dose, and they're going to ask the patient if they have a funny taste in their mouth, any ringing in their ears. If so, that is a guide to let us know that maybe that medication was injected into the bloodstream and not into the spinal canal there where we're trying to get that epidural space. Typically, nausea and vomiting are the first things we're going to see with hypotension, but honestly, the easiest way to know if mom's blood pressure is dropping is baby. Baby's heart rate will drop real quick, and you'll know that, especially if it's right after epidural, mom's blood pressure is also dropping. So we'll increase those fluids and keep them running, get mom rotated onto her side, some oxygen, that kind of stuff. We're going to be checking that blood pressure every 1 to 2 minutes for 15 minutes after. Usually during the process of having an epidural placed, they're just going to constantly be taking blood pressures. So basically every time that blood pressure cuff releases, it's just going to wait a couple seconds and blow right back up. So then after that first 15 minutes, we'll slow that down and take the blood pressures every 15 minutes. And we'll continue that. Sometimes we can move to every 30 minutes depending on how long this epidural block is in place and how stable mom's blood pressure is. So you can move it out to every 30 minutes, but we're going to be taking lots of blood pressures. If we see that mom's blood pressure is dropping, we're going to turn mom to her left side, increase her IV fluids, put her O2 mask on at 10 liters. And usually at this point, our anesthesia is still at the bedside, and they'll give some ephedrine to help increase that heart rate back up. But usually we try to do these other things first, turn mom over, increase IV fluids, and give her some oxygen, and those things will take care of that. Okay, so other things that we can do for pain medication, for labor pain. So you can give opioids. So it doesn't really take away the pain. Typically what I see happen is you give the first dose. That first dose makes mom very sleepy. She gets an hour nap, maybe a 2-hour nap. Then after that, you can continue to give the pain medicine, but it doesn't work as good as it did that very first time. So you have to remember that opioids do cross the placenta. So once mom gets into that 9 centimeters, 10 centimeters stage and pushing, I'm not going to be able to give mom any opioids, because then I'm going to have a baby that comes out and doesn't want to breathe. So we have to be really careful with that. Nitrous oxide is something that's being used a lot in Europe for sure. It's being started to be used here in the United States. So basically it's nitrous. It's there at the bedside. It's a lower concentration. Mom can breathe that in, and then once she gets some relief from that, she'll pull it back from her face and then get some rest while she's not having to worry about feeling every single contraction. It seems to not interfere with the labor process. I think we'll see it used more and more as we move through the stages, but I have not seen it used around in our parts. Now, North Florida may or may not be using it. I'm not sure about UF either. I know some of the smaller facilities are more working with epidurals and some other pain medications. All right, so now we're in our second stage of labor. So that's pushing, right? I've got to 10 cms now. Now I'm going to push. So if we're 10 cms, the patient can start pushing, but here is the thing. If they push too early and there's still a little bit of that cervix, that whole thing can swell up and really cause some problems. So we don't want them to start pushing too early for sure. We're going to make sure that bladder is not descended, and we're going to watch the color of that amniotic fluid and make sure there's no changes there. All right, so our third stage of labor. This will be from the complete delivery of baby through the delivery of the placenta. Okay, that's our third stage. So that can last 5 to 15 minutes. The longer it lasts, the more at risk this mom is going to be for hemorrhage or uterine atony. Uterine atony just means that that uterus is not wanting to clamp down, and we need, once the baby delivers and that placenta comes out, we need that uterus to clamp down so the bleeding is not a lot. So why would moms have this much bleeding? So think about our placenta, right? So that placenta is attached to the side of that uterus. If it comes off, depending on whatever size that placenta is, once that comes off that wall and is delivered, that whole area where that placenta was attached is going to continue to bleed. So we need that uterus to clamp down, so that will help stop the bleeding. Okay, hopefully that makes sense. And we will talk about this more. So how do I know the placenta is getting ready to deliver? So there'll be a gush of blood because that placenta is detaching, right? So we're going to have a gush of blood, and you're going to start seeing that umbilical cord that's kind of still hanging out is going to start getting a little bit longer, okay? Usually once the placenta is out, we're going to increase that Pitocin. That way it is running very quickly in a bolus manner. We do have to be careful when we're talking about Pitocin, how long mom has been on Pitocin. If it's been a lengthy induction process, then those oxytocin receptors in the brain get full of oxytocin, and they're not able to help get the body to switch over into the cramping and clamping down of that uterus. So we will give mom a bolus, but it's possible that we may have to then move to other medications if it's been a lengthy oxytocin kind of a induction period. So our fourth stage of labor is now 1 to 4 hours after delivery. Usually 4 hours is the golden standard there. That's what we consider the recovery period. So it's going to be just like recovery in the OR. You're going to really have to watch your patient, stay on top of doing fundal massages and looking at bleeding, making sure that patient's bottom is intact, all those kind of things. So what am I meaning about this? So what I'm going to be doing as the labor nurse, every 15 minutes for an hour, I'm going to be assessing that fundus. So remember I said the fundus was the top of the uterus. So that's what I'm looking for now. Once baby and placenta are out, that uterus should shrink back down to about grapefruit or softball size, and it should be very firm, just like a grapefruit or a softball. Okay, very firm. And that's how we need it to stay for the entire time. Okay, so that those blood vessels are not bleeding, actively bleeding. So every 15 minutes or so, we're going to be massaging that fundus. It's uncomfortable. Okay, it hurts. If you've had a baby, you will remember fundal massages. okay, because they are very uncomfortable. But that's something that we have to do. I've had patients attempt to hit me. I've had patients attempt to, pull my hair, do when I'm massaging a fundus. So as a labor and delivery nurse, you get used to throwing hands and trying to dodge and weave different things. Okay, I've had a patient try to bite me, but I still have to massage your fundus. Okay, so sometimes that means having a very strict conversation with your patient about, I have to do this. It doesn't feel good. It hurts. It's uncomfortable. If you can't restrain yourself, I'll bring somebody else in to help me to keep those hands back from whacking me in the head while I'm trying to do my job. Okay, because it's important. So we're going to be assessing the firmness of that fundus every 15 minutes for an hour. Then we'll do it every 30 minutes for 2 hours. Now, if mom's bleeding heavily, it's going to be even more frequently than that. Okay. We're also going to be looking at her bladder, because remember we talked about that bladder. While it's good to help push that uterus up when mom is very early, now at these later stages we need the bladder to stay out of the way, so we need to make sure she's voiding. Okay, we're going to watch the amount of bleeding, that's lochia, and we're going to look at the perineum. So maybe she had some tears. We may be assisting the physician or midwife in doing the repair of those. Sometimes that can be rather extensive, so depending on what's going on, we may be involved in this recovery process a bit longer. Okay. So again, talking about the fundus, I mentioned all these things. We'll talk a bit more in class. Lochia should be rubra, which is red. It should be moderate, and they will have some clotting. Now, mom sits in bed for a prolonged amount of time, like I work day shift. If mom slept for several hours and laid in the bed, the first thing I'm going to have them do before I even assess the fundus is have them get up and go to the bathroom and void, because again, that bladder is going to get in the way of what we need to do. All right. Plus, if she's been laying in the bed for several hours, that blood is going to accumulate in there. When she gets up, gravity is going to take over. It's going to come out. They're going to freak out because it's going to be a very large clot in the toilet. And so we need to reassure them that that's going to happen and it's okay. As long as she doesn't continue to drop clots like that, then we're okay with it if she's been in the bed for a bit. We're going to look at the perineum and make sure it's intact. If mom had an extensive repair, we're going to have to really look at it, because they can get really bad hematomas in there. And that's just that collecting of blood where it's bleeding underneath the surface. Usually the people that have the problem with these are people with extensive repair work. And we'll talk a little bit more about that in class. Okay, so molding of the fetal head. So the baby's head, the skull, is made of floating bones at this point. What do I mean by floating bones? They're not all connected to each other right now. All right, there's a couple of reasons. First, if baby's head was not, if it stayed very firm on the way out, there's no way for that baby to get through all the different movements it needs to get through the pelvis and then be able to be delivered. All right, so that's one reason why those bones mold, so they can cross over each other. The bones, they'll cross over the fontanelles, which is the open area, and that's why you get babies with the little cone heads, right? The other reason they're not fused, that skull is not fused, is because a baby's brain is not done growing yet. So as the baby is growing and getting older, the brain has to grow as well. So those are a couple of reasons. This molding will go away Usually that first day they may be very cone-headed, and then as each day it'll look better and better and better. But baby will look different every single day, because if baby had a lot of molding, then the face will probably have some swelling. So each day that swelling is going to go down. We do not have to worry about shaping the baby's head. I know a lot of our old timers like to say that the baby's heads need to be shaped or they're going to stay like that. They aren't going to stay like that, I promise. They will come back into a normal skull shape. It just may take a little bit for some of them. Okay, so bonding in the golden hour. So what do we mean by that? So that's that first hour of mom and baby being able to be together. This is when we like to do skin to skin. If mom is not available for some reason, then dad is a great second choice. It just promotes bonding. Skin to skin is great with helping with baby regulating their temperature. It keeps them warm. Typically in a labor room, it's going to be very chilly because mom is going to be very hot, right? I've just gone through this labor process. I have all these hormones shifting, so they tend to be very, very hot. So having baby do skin to skin with mom is very helpful. It also helps them settle down their vital signs. So if I'm not breathing, if I'm breathing very fast, it's good to do some skin to skin with mom. They settle down faster. Of course, this time allows mom to go ahead and get a good breastfeed in if that's what she's planning to do. You might want to turn the lights down some so that baby can open its eyes and look around. We typically now are trying to not do the eye prophylaxis so early. Same with their vitamin K injections. We'll put some of those things off as much as possible because we really want mom and baby to have that time to be together. Okay, that baby is most awake right then, right after delivery. Then they get very sleepy because you have to remember they have also been through a very traumatic process. So that first hour we want bonding. If it's not with mom, then we'll get dad to be the step-in person for that. So then we'll discuss some safety measures with mom and dad as well. Okay, so this is a good representation of what baby really looks like when they come out. The last slide, that baby had clearly been wiped up a little bit. So this baby in this picture has got lots of vernix on it. That's that cheesy substance that we discussed. It's a moisturizer. So if baby is really cheesy, this one is kind of cheesy, okay? We're going to go ahead and wipe some of that off just because it's going to keep their skin very wet, and we want to try to manage baby's temperature, and part of that is getting off the any of that wetness. We want them to be dry. Okay, so if for some reason I can't do skin to skin with mom right away, then I'll put baby under the baby warmer and I'll go ahead and do some of these things. Suctioning the mouth and nose, they can use a bulb syringe, but they're not using it as much as we used to. It used to be standard, like mom's pushing, baby's head is out, and they'll start suctioning then with a bulb syringe. And baby's not completely delivered yet. Now the shift is to trying to not do that unless we absolutely need to. We're going to do an Apgar score, and we'll talk about that on our next slide. We're going to look at the cord, remember, and we're looking for 2 arteries in the 1 vein. Vernix is what I described over here in this picture. It's that white substance that keeps the skin very moist. And then we're going to look for breathing issues. Okay, so when they first come out, if they come out in a rapid descent, then it's possible that they didn't get a really good squeeze on the way out. And why is that important? Well, remember, baby on the inside of mom is breathing in fluid. So now I need that fluid. Baby's going to shift from breathing fluid to breathing air in a very rapid amount of time, right? I'm being pushed. As long as that cord is still clamped, I'm getting what I need out of that. Is unclamped. I'm getting what I need out of that cord. But once I'm out and the doc clamps that cord, now my body has to shift. It has to go from being dependent on mom to do everything for me. Now it's my turn. I have to start doing this myself. Okay, so if it's a nice slow process of coming out, then I'm going to get the squeeze that I need to get that fluid out of my lungs. If not, if maybe mom has had several babies and pushes very easily, baby comes out quickly, I don't get as good of a squeeze. And then if I'm a C-section baby, I get no squeeze. So depending on what's happened, I may have some extra fluid in my lungs. So things that we're going to look at then as far as respiratory distress is the baby having retractions. Is it tachypnic, breathing greater than 60? What does the color look like? Is the baby grunting, or is the nares flaring? Okay, when I talk about Apgar, Apgar is the acronym for activity, pulse, grimace, appearance, and respiration. So what I'm looking at is I'm going to score this. So again, this is another indicator, another scoring system that will allow us to give report to our pediatrician if they're not at the delivery. This allows them to say, to understand what did the baby look like when it came out and how's the baby doing now. So we score baby at 1 minute and 5 minutes. That scoring will continue about every 5 to 10 minutes if the baby has less than a 7 on the score. Okay, so let's talk a little bit about how we score these babies. Okay, so for activity and muscle tone, either it's going to be absent. Remember what I told you, babies should be flexed. Arms and legs should be flexed in that fetal position, right? So if I have my baby and the baby's laying and my arms are flat out, my legs are flat out, I'm concerned about what's going on with that baby, okay? Baby should either have their arms flexed or be very active. Maybe I'm going to be wiggling around. That's fine as well. That's great activity. I get 2 points for that, okay? My next thing is pulse. Is my pulse absent, below 100, or above 100? So above 100 is normal. Below 100 is a little slow, but that's better than absent, correct? So I will then give score for that. Grimace is about that reflex irritability. They just call it grimace because it fits better in that system, right? So is the baby floppy? So if I pick baby's arms up, we talked about their muscle tone, their arms just laying out, right? If I pick up their arm and it just drops back to the bed, that's floppy, okay? If I pick up that arm and then baby pulls it up close to them, then they're doing those things that I need to do, and that's considered a minimal response. For 2 points, that baby is, if it's kind of just laying there, it may be flexed a little bit, or it maybe I'm stretching a little bit. My arms are out, but if I stimulate the baby, they should either start moving again or come back into that flexed position, okay? The next one is appearance. So am I blue? Am I pink with blue extremities, or am I pink? Okay. So it's very fascinating to watch these babies sometimes, because you can see as their body is switching from that internal environment to the external environment. You can see the pinkness start to creep up their body. Okay. So what the body is going to do first is I'm going to take care of the things in the trunk and in the head. And why is that? Well, really we can live without arms and legs, but I can't live if my trunk where all my organs are at, or my brain does not get oxygen. So those areas are going to be oxygenated first. So that is why they said that you might have a pink body but blue extremities. That's okay. It's called acrocyanosis. It will go away. All right, so we'll watch baby and make sure those extremities start getting some blood flow to them. Or baby may come out screaming, and if I do, that screaming helps with the switching of all the little pieces of that fetal heart that are open. It helps close all those, and it moves this process along faster. So those babies may come out and be completely pink. We're good with that. Respiration. So am I not breathing whatsoever? Am I breathing some? Is it a slower rate, less than 40? Or am I crying vigorously? So that's how I score respirations. All right, for our last slide, this is about newborn care. We will continue to discuss this later, but this is that first kind of how mom has a recovery period, baby does as well. So we're still in our kind of our transition period, so to speak. So we want to encourage that skin to skin with mom for the first hour. These are things that we want to talk to mom about before delivery, because we need to know, is she going to breastfeed, and is she willing to do skin to skin right away? Some people want baby cleaned up before they do skin to skin. So those are things we need to know before delivery, okay? Skin to skin can be extended for longer than the first hour. I've seen in many babies that they continue to do skin to skin as long as baby is in the hospital. Some people even continue to do it once they get home. It does keep baby warm. It helps to regulate the temperature. So those things are all really important. It's great for breastfeeding because then baby can smell mom, mom can smell baby, and those are some triggers for those chemicals to release and for moms to start her milk supply starting to produce and move forward. So those are all really good things to do. So the 3 medications that we'll be using for baby is your erythromycin ointment. So that's going to go in the eyes. So erythromycin and vitamin K are state mandated meds that we give. Yes, mom can decline them, but I always usually make sure that they understand why we give them and why they're important. And typically your hospitals will have some sort of a consent or something that says I'm declining this erythromycin and vitamin K, which is fine. They just have to understand what the risks are, okay? So erythromycin ointment is a prophylaxis. It prevents gonorrhea or chlamydia infections in the eyes. If baby was to pick this gonorrhea or chlamydia up on the way out, then it is possible that it would cause blindness in babies. So that's why they just went ahead and state mandated that everybody get it. Vitamin K is given IM and right in the thigh, in the vastus lateralis. This prevents hemorrhage, okay? So babies are born without the ability to clot. So I'm not sure if you went into this in med-surg, but in order for us to have this ability to clot, we have to have some protein in our system, right, of some sort, and it has to be processed through the small and big intestines as it goes through. So remember, babies on the inside, I'm not ingesting any protein. So it's going to be after several feeds before I get some protein. It gets digested, and then vitamin K starts to kick in on its own. I would caution you about not receiving a vitamin K injection, especially if you're planning for baby to have a circumcision in the hospital, because without this vitamin K, there is little to no clotting in the baby. So you may end up with a baby that is bleeding out from a circumcision, okay? I had a pediatrician that cared for a family that delivered at home. He came to the home to see the baby. Not exactly positive how he got involved in the conversation, unless it was a family member or something. Anyway, he was called to come to the home, and the baby actually bled out from a circumcision at home because he was not administered vitamin K. So I do caution people, if they're not going to take that vitamin K, that they really understand why it's important. Okay. Hep B vaccine is recommended for all newborns. Some of your pediatricians will ask you to please wait and have that first dose started when they see you in the office. It is important to go ahead and get this vaccine started since it's a 3-shot dose. But those are things you need to discuss with your pediatrician before you are admitted and have a baby.